5, my mother was paralyzed. My father was a physician, but my mother was paralyzed. So the two of them, for different reasons, had an influence on what I did in life. I've always been interested in martial arts and athletics and in preserving one's ability to enjoy their lives and return to the highest functional level. So this is basically my background. As I went through my training, I was fortunate enough to do 2 spine fellowships, one at the University of Kansas under Ray Jacobs, Roger Jackson, and Mark Asher. And then I received an AO scholarship and went to Europe and was able to work with Erwin Morscher, Fritz Magrol, and work with Jürgen Harms, and developed a depth of training. Then I was recruited to the University of California at Davis in about '86. I started my career there and I did the adult spine. And so in the late '80s, was my first encounter with motion preservation. I had a patient come in, and that patient had a 3 or 4 level procedure done 20 years prior. So he had a 20-year window where he had excellent results. And I thought, since I was the new guy there, that people were breaking me in and teasing me. And so I saw these x-rays. First I saw the lateral, and it had these stainless steel balls. So there were these circular balls in the disc space. And I thought somebody had taken the time to tape pennies or something on the person's body. But then I saw the AP, and it was also on the AP, so there's no way. This had to be in the disc space. And so there was a person who was operating up in the foothills of California who had gone over and learned how to do the Lindstrom ball, which was a stainless steel, 316L stainless steel ball. And so that was so I tell people I had probably a longer experience dealing with disc replacement or motion preservation because of that. A lot of times people will say, how long have you been dealing with disc replacement? And I'll say, well, over 40 years. And I'll say, that can't be right because it's not been around for that long. But that's what makes that statement true. First of all, I don't trash the fusion. Fusion is a great operation. It's been around since the late 50s. I still get excellent results. And the way I describe it to people is that when you have failed conservative treatment and we're thinking about moving on to surgical treatment, if everybody that's a candidate for a surgical operation, I describe it in terms of circles. So if everybody that's a candidate to have a fusion is a large circle, those people that are candidates for a disc replacement, that's a smaller circle, completely housed inside of that larger circle. What does that mean? It means everybody that's in the little circle, they're candidates for a disc replacement. They're also in the big circle, so they're also candidates for a fusion. But there's people that are in the big circle that aren't in the little circle, so they're candidates for a fusion and not necessarily a candidate for a disc replacement. What I also tell people is that smaller circle seems to be growing. So there's situations that maybe 10 years ago, I might not have recommended a disc replacement, that I'm now recommending a disc replacement. And once again, it's with informed discussion. 10 years ago in the cervical or lumbar spine, if I saw facet problems, I might tell the patient, you can't have a disc replacement. If there's severe facet problems, I'm still going to tell the patient that, but it's an informed discussion and they're able to make the decision, well, I want to try. But in my hands, that little circle is growing and more patients are candidates in my hands for a disc replacement. They recover sooner, they can get back to what they want to do sooner, and it preserves motion. So in my hands, interviewing them, I seem to be hearing that they don't really notice any loss of motion. Whereas the fusion people, even the ones that get a great result, there is a loss of motion. Now, there's some caveats. There have been people that I've done disc replacements on. They were absolutely emphatic that they only wanted a disc replacement. They were fighters. They had the disc replacement, and then they self-limited themselves later, and they did not return. And they came back to me and they said, you know what, I think I probably should have had a fusion done, and I'm not going to go back to competing. We know that there's many people playing professional football, a lot of professional contact sports with 1 and 2 level fusions. Many people, so this has been time tested. So if you were a high level champion, I probably would still tell the patient to consider a fusion. Everybody has some activity, recreational activity that they like to do. But even if you don't, even if all you do is work at a desk, you know, we're using computers, we're using cell phones. People have greater satisfaction in my hands, in my experience, when they've had a disc replacement done. And once again, I see patients come to me and they've talked to other people who've trashed the fusion, and I tell them, listen, that information that you may have received is not correct information. The fusion is still a good operation. They seem to hone in on fusion versus disc replacement. And I say, no, you have to start at the beginning. Motion preservation to me is getting the patient rehabilitated and their muscles strong and not having to have any surgery. That's the ultimate in motion preservation. Step 2 is using alpha-2 macroglobulin, that protein that I talked to you about. Whether it's an intradiscal or facet injection or flooding the area with this protein, I've had great success and have had situations where people have not had to be operated on. And to me, that's motion preservation. Now, when we get into the surgical realm, I think that, you know, motion preservation leads to increased satisfaction. Now, the exam question is that at 10 years, people who've had a disc replacement have a lower reoperation rate. That is clear in everybody's mind. You'll hear some papers going back and forth regarding satisfaction. In my hands, I feel that the level of satisfaction is greater with a disc replacement. You'll hear people talk about adjacent levels. Now, we talked about earlier that absent any surgery, people have adjacent levels that break down. When you have a herniated disc, you are in a situation where you had a higher statistical chance of having an adjacent level breakdown than if you have not had a herniated disc. It's my belief that if you have a fusion, you then increase that chance, and compared to a fusion, if you have a disc replacement, that chance is lower. The other thing that you have to understand about adjacent level breakdown, just because an adjacent level breaks down doesn't mean that it's symptomatic. So we have to be comparing apples with apples. And we have to know, did this person develop a symptomatic adjacent level breakdown or just an adjacent level that broke down and it's not symptomatic? Many people come in for follow-up 5 and 10 years later and they have no symptoms, but there's an adjacent level that's broken down. I think that there's no particular area where it's more beneficial than any other area. It's a matter of having pain-free normal range of motion or near normal range of motion. And it has to be that you have it to the level where you're not conscious of it. That's the situation. I've seen people post pictures of people, you know, on the mat that have had, and they're just not moving right to my eye. As a black belt in jiu-jitsu, I know the way a person's supposed to move and the way the person's not supposed to move. So it's usually going to be, I'll let them start doing non-contact stuff at about 2 to 3 weeks. but usually I'm going to want to wait about 3 to 6 months before they can actually return it. I'll depending on what they're doing and at what level, it's probably going to be 6 months.
Gotcha.
But I'm going to have to just basically see what they can do. The person who's not a full contact athlete, they're going to be able to resume their activities sooner than a person with a fusion. But if you're asking to participate in a full contact sport, you're basically wanting full incorporation or ingrowth into the disc replacement, which follows a similar curve to fusion healing. The only difference is that the fusion is more time tested. So we've got hundreds of people that have returned to full contact sports, maybe even thousands that have had a fusion, probably in the thousands. We don't have that experience yet with the total disc replacement. And each patient has to be on a case-by-case basis. I can foresee that there might be a situation where I do a total disc replacement that I tell a patient, I don't think you can return. Just like there could be a situation where I do a fusion and I say, I don't think you can return.
Got it.
So I make sure that they know that ahead of time. And the funny thing is, it's not a funny thing, but I have people come to me all the time and they say, oh, I came to see you because you're the guy that lets people go back. And I have to explain to them, A, I don't let everybody go back, no matter if you have a fusion or not. And B, there are certain models, makes of disc replacements that I think are way more stable than others. So I don't want to say something negative, so let me say something positive. If somebody wants to go back to a full contact activity, the only disc replacement that I'll consider is the original Pro Disc with the keel. If somebody comes to me and they've had some other disc replacement done, I'm not going to give them my okay to go back. That's something that they're going to have to decide on their own. And there are certain disc replacements that I definitely would say you can't go back. Some people, the incision is almost imperceivable, and so their opponents may not even know. So I would say that it's on a case-by-case basis, and it's with informed consent, and it's with the patient signing that we've gone over everything, and that there are risks of returning, and they accept those risks. But I think in their particular case, they're in that category of potential people that can return. So once again, it's on a case-by-case basis. Some people are able to put out of their mind that they ever had a problem. And as I said earlier, some people, you do a disc replacement and then they end up talking to other people later and they change their mind about it and they self-limit themselves. And they come back to me and they say, I decided not to return to, I'm teaching now, but I decided not to return to competition. I like to rehab the person and get their muscle strength when it's applicable. Sometimes people are in too much pain to do things, but if usually I can get them to strengthen their muscles beforehand, and that helps with the rehabilitation process. You can come to me and you can appear very muscular and still have weak neck muscles. You can come to me and appear relatively muscular and still have weak core. So I try to have the individual strengthen their core muscles, their neck muscles prior to the surgery, and that helps with the rehabilitation. And then after surgery, I want them to get up to the same strength that they were or greater. Usually they can surpass that post-surgery. I constantly hear people say, oh, this is Dr. Montesano's opinion. I don't agree with that. So I try to give people, this is the exam question, this is the exam answer. So I'm constantly taking tests. One, test that I took recently included internet medical information. And one of the answers was that 80% of information that's on the internet regarding all of medicine has been placed there by non-physicians. Another question had to do with what percentage of the information is true. And the answer was, regardless of who put it there, 50% of the information on the internet is true, 50% is false. I encourage people to get as much information as they can, and I always tell patients, the more you know, the better you're going to do. I encourage people to write questions down, because people will come to see me and they'll forget, they'll leave, and oh my God, I forgot to ask them. And I do that too when I go to the doctor. I meant to ask this question and I forgot to ask it. So I encourage people to write down their questions so that we can go over them when we are together. But once again, it's a shared risk. When you're returning somebody to competition, if that's what you're talking about, it's a shared risk. Once you're injured, you're never going to be the way the Lord made you. I can't put you back like that. I can make you better, but I can't make you normal. If you meet certain criteria of instability or advanced arthritis of adjacent joints, the facet joints in the neck, the facet of the joints, if you're a candidate for, if you're one of those people that's in that inner smaller circle, then it's just your understanding. There's a big difference between somebody who understands. Sometimes people come to me and they don't want to listen to my little talk on disc replacement versus fusion. And I think what makes a big difference is if you're open-minded, if you really listen, if you understand, if you can accept the information I'm giving you, and then I allow you to make the decision. There is a big difference between somebody who is closed-minded and doesn't want to listen versus somebody who listens to the pros and cons and then makes a decision. And I want you in that second group. Now, I think I said earlier, let me say it again, I'm not going to let you return if you have more than 2 levels. I'm more likely to let you return if you have 1 level. If you have 2 levels done in your neck, let's say, you don't have the same likelihood of returning if you just have a 1 level. You still have a likelihood of returning, but it's not as great as if you have just a 1 level surgery. I'm a little more inclined to let you return in the lumbar spine, because you have to think of the spinal cord and the cauda equina, the nerves that exist in the lumbar spine. You have to think of them as 2 completely different organs. Your neck and your lower back are completely different. Know what your body's telling you, and maybe you can avoid being a surgical candidate altogether by coming to me early, by strengthening your neck muscles when you just have a little bit of discomfort and you don't have excruciating pain. Coming to me before you develop weakness in your arm, that that burning radicular pain that's going down your arm or going down your leg. So it's being aware, being proactive. I still think too many people are getting surgery that might not necessarily need to get surgery if they went through the proper rehabilitation, got the neck strong, et cetera, et cetera. I think that there's going to have to be alternative metals used. I'm getting people telling me that they have nickel allergies that they weren't aware of. I do not think it's the standard of care to send everybody out to see what they're allergic to. Otherwise, we'd be doing this for a wide variety of total joints, hips, knees, etc. I don't think that's the standard. And I don't think that everybody that thinks they have a nickel allergy really does have one. But I think if I were to want Sentinel to give us something else in our bag of tricks, it would be an implant that didn't have nickel in it. But we'd be chasing our tail, because then there'd be something else. There'd be a group of people that had an allergy to whatever that was made out of. So these things, there's just no way to screen for them. I don't think it's the standard of care to be screening, and I think you just have to deal with it when it does. I've been using more and more of alpha-2 macroglobulin. The area that I'm most confused about, and I think it's confusing for a surgeon, that we look on the internet and we see these claims of stem cells. I'm not sure that there's really much in the way of FDA approved stem cells. I've heard of one company out there that has FDA approved stem cells. They were originally approved, I think, a few years ago to combat the host rejection in the pediatric area. And I think over the last year or two, they've been offered to people with musculoskeletal problems. The cost is staggering. I only know of a couple of cases where people have gotten that. I'm not sure what's really available in other countries, if that's real or not. My tendency is to think that it's not real. I've had patients go to other places and ask them if they could bring a vial, and whatever was being injected to them be put in the vial, and it's been refused. And I'm a little skeptical when that gets refused. I do think stem cells are the way of the future. I don't know that we have those really available now. Once again, I go to exam questions, and I recently took an exam where that was one of the questions: are there any readily available clinics? And I put no, and I got that question right. So I don't really understand what's being talked about on the internet. It's confusing. I wish there was more control over that, so that we as physicians would be able to know what was real and what was smoke and mirrors. But I do think it's the way of the future. I enjoy when I see other people enjoying their life. And it may go back to my early childhood, the fact that my mother was paralyzed, and it really took her life's enjoyment away from her. So I want to try to preserve everybody's ability to enjoy this life.